Okay, thank you very much. I've just been having a quick chat with Lee, of course, and there's nothing like the two of us being set up to fail, being somewhere in between Winford and your lunch, yes? Not a lot of room left for us in the gap, yes? In all sorts of senses. I'm also not... so thank you very much for inviting me, but I'm not going to be able to talk about the thing that I think I was invited to talk about. So I'm currently doing a review of the Welsh Government substance, what's called substance misuse harm policy, with a couple of colleagues from Scotland. And typical with the way in which Welsh Government behave, actually there's quite a lot of handcuffs on us about what we can and can't say. And we're due to report to them in May and probably publicly available sometime in the summer. What I am going to do, though, is talk about why it is they asked us to choose a particular methodology and what that might say about some of the conversations that have been had this morning. And in particular, I think, following on from Winford's, at some level, about how the fact that there is far more, and along with Mark's as well from Alcohol Concern this morning, that there is far more that contributes to our understanding of what actually gets people into the place in which they may or may not have what people might call addictive behaviours, and the way in which they get out of it, and how on earth we can actually understand what contributes to it, both from agency activity and then other activity. So I'm going to try and say something of that nature, really. In the end, this becomes a conversation about outcomes, and anyone who's been in and around drug and alcohol, let alone other forms of behaviour at the moment, will realise that people keep talking about outcomes. Well, no, they keep using the language of outcomes, but don't talk about outcomes, and I'll try and explain what that means. I'm going to talk about the range of factors that probably contribute to people to change. And once we begin to understand that complexity, how difficult it is for anyone to capture what is actually making a difference. Some of the methodologies with this, I'm going to talk about one particular methodology in detail, which is the methodology that the Welsh Government have adopted at this point in time to ask us to review their strategy by and their policy. And it's one that's a very dominant one in Scotland at the moment. And I'm going to suggest what are some of the implications of that position. Okay, so the conversation really starts with the idea that for a very long time, in relation to a whole range of interventions that provided to support people with a range of behaviours, but particularly drug and alcohol, for a long time we've been focused on outputs. Outputs are usually just related to variations in the consumption of drug and alcohol or not. But actually very often all that happens, and I think Winford's absolutely right in that story, is that people actually achieve that goal and they're put back out into the same melee and then they just come back. It's what we call the revolving door syndrome. And much more recently people have begun to talk about outcomes. But really when they mean outcomes, these are still what we would call in-agency outcomes. So they are partly in-agency outcomes because the only time we're ever collecting them is from people while they're in services. Yes? So they're not about the outcomes that they've gone on to have after they've left a very narrow bands of treatments. But they're also in part in-agency outcomes because they're very often directly connected to the nature of the intervention or the treatment they've been receiving. They're not necessarily actually related to the outcome that the individual wants and or the society wants. And in terms of course policy and public health, these two things aren't necessarily the same. So the classic example at the moment is that the Welsh Government might, for example, want to see some reduction in criminal behaviour and or drinking, and while some people engaged in both those activities might also want to stop that, they're far more interested in a better connection with their family. Yes? So there's a mismatch here. Yes? So what we arrive at is a set of outcomes that we want as a society and a set of outcomes that the individual wants. And increasingly, as we begin to understand those, they become more and more discordant from the actual treatment intervention. Yes? Yet the policies will have the big outcomes. And yet the things designed to deliver the policies are broken down into some very narrow, compartmentalised, micromanaged projects, funding streams and everything else. Yes? And the explanation for this mismatch and why it becomes increasingly difficult no longer to evaluate or measure policies, hence why people have moved to some other forms of methodologies, is quite simply to begin to be able to put it like this. And this is a very simplistic diagram for an incredibly complex picture. So we can sit in the middle and suggest that the aspirational part now is the individual and societal outcomes, and some of those are over a range of life, and they're not just the narrow outcomes of any one particular agency or intervention. And we can begin to say that there are a whole range of things that may contribute to achieving those outcomes. Yes? And we've heard about some of those today. So very narrowly in the internal space, we've actually heard about some of the stuff associated with psychology and the individual's way of thinking. Yes? But there are many other parts of the internal situation that contribute to all of this. And we've heard references to things like childhood experiences and family, individuals' resilience. Another space you'd hear a lot of people talk about people's recovery capital. And we can just continue to go on with this sort of list. We can also suggest, as has also been alluded, that we can devise interventions that might impact on this behaviour, what we call provision. And of course, most people involved in this arena usually do not receive interventions from one agency. So already, when we're trying to measure the outcomes, we're trying to say, well, how did 5, 6, 7 or 8 agencies contribute to all of that process? Yes? But we've also begun to hear today as well that there's a whole set of other things that go on. So it's not just the manualised therapy intervention that contributes, and yet that may make a contribution. In other words, there is an evidence base that says some might be more effective than others, but we can begin to get the worker variable. And there are a whole range of worker variables, and Winford has suggested one for you, for example, today, about whether or not a worker is compassionate or not. Yes? So all of these things begin to contribute to what extent an outcome is or is not achieved. Yes? Some of us who've been working in around drug and alcohol services know for ages that one of the most important things is the nature of the greeting you get the moment you come through the door. So there's a million of these things. And these are only 2 of 3, 4, 5 parts of the jigsaw. And I've suggested 2 other parts here, and the bit that we've been trying to engage is policy, and I'll come to that last. But of course, there's a whole set of external factors. And if you were to go and find a Manchester City fan now, as opposed to a Manchester City fan 10 years ago, their overall well-being and happiness in the world has been vastly improved by a very rich person buying their football club. That's their outcome, their sense of well-being. But at what point in time is that tied or disconnected to, or related to, or connected to all the other behaviours they're getting involved in? Yes? At what point in time will the Welsh nation become happier under global warming if we get more sunshine, or more miserable if it involves in even more rain? Yes? Apart from those of us that like rain. Yes? Yeah? And we can talk about some very odd, bizarre external things, and we can talk about some very practical external things as well. So we can talk about things like Brexit. Devolution's a huge issue. If we bring it right back down to substance misuse, the Welsh government is losing the opportunity to bring in minimum unit pricing, for example. The Wales Act, which will decide where we have conferred or reserved powers, will almost certainly make it impossible for Wales to go it alone on minimum unit pricing, and will be subject, therefore, to the will of the UK Tory government, who will never go there because they're in bed with the industry. The Scottish government will go somewhere separate, and all of a sudden, that's a variation on outcomes in relation to drinking. Yes? So it becomes this massively complex picture, and then they come and ask people like us to evaluate the policy. Yes? Review the policy. Yes? And of course, we always talk about review the drugs and alcohol policy as though it's a standalone issue. Yet we know that most people in drug and alcohol situations are equally as affected by housing. And what you've done with a housing policy is going to affect the outcomes. Yes, we know at the moment that there are far more people that are homeless as a consequence of a benefit strategy, and their homelessness is affecting their drug and alcohol use. Yes, so is the increase in drug and alcohol use a failure of the drug and alcohol policy or a failure of the housing policy, and all of these type of things. Yes, and it begins to say to us, of course, that then what happens is we begin to revisit some of the traditional methodology. We've begun to look at these sort of things, and this is an incredibly crude diagram. Literally designed for a 15-minute talk. But it would suggest, as we move across this progression of moving to the more longer-term whole society and individual outcomes, that the nature of methodology we have to do stems increasingly away from what can actually be finitely measured. Yes? And we have to move increasingly to both complex methodology, but methodology that doesn't necessarily easily for us to be able to go, A plus B has equaled C. In fact, we're already being asked to consider, as I've just suggested in the previous diagram, that A plus B plus C plus D plus E plus F, G, H, J, Y, K, and L may possibly have contributed to Z, but in fact there might be a whole other things that have contributed to Z that we didn't actually count for in all of that process. Yes? And so what's happened in relation to beginning to evaluate what we might broadly therefore call public health policy across a range, or we might call it health and social care policy, whichever sort of language you want to consider, is that governments have begun to, and really the Canadian government started off on this journey more than anywhere else, particularly in a bunch of Canadian academics. And for those of you who want some of the references about this particular methodology, they're on the last slide here and be given to people. And then much more recent in the UK, over the last sort of 3 or 4 years, the Scottish government have done so. And then the Welsh government have done so in this occasion of the substance abuse review they've asked for us. They've begun to adopt something which is called contribution analysis. In other words, you begin to review by policy by beginning to say the extent to which the activity of the policy and the policy itself might have contributed to some of the measurable outputs. But a realization at some level that you can't actually say it has caused the outputs. Yes? And this methodology, in the most simplest sense, actually requires you to tell a story. And that's actually the whole point of the methodology. You're required to begin to suggest what's the starting points, yes? What's the journey that's been on, what are the measurables within that journey, so we can actually collect up some of the stuff from the in-agency outcomes. We can even collect some of the very narrow outputs. And we come along to it and suggest where have we arrived at. And to what extent has the policy made a change? I said before, I can't necessarily report too heavily on what we've done with Welsh Government at the moment because of the way Welsh Government behave. But what's become really interesting in doing this methodology with the Welsh Government, so we're at the point in time in which we have just gone through virtually all of these stages, and we've just been reviewing our findings with a whole set of individuals. What we've begun to find out is at one level, policy does, and this is a very common thing for contribution to find, policy and activity will, of course, in part do what it says on the tin. Yes? In other words, these shorter outputs and outcomes can be done. In other words, in Wales, if we set up an naloxone project, an naloxone project will have some impact on whether or not we reduce deaths. But we get blip years, which confuses that sort of stuff. So we can do that sort of stuff. If the Welsh Government sets a priority and then sets out a funding stream that says you can have X money for this particular form of harm reduction, or you can have X money for improving Y, some of that will happen. However, if we then take it against the larger outcomes, we can demonstrate an inordinate amount of activity, and some of that's been achieved, but not necessarily against the outcomes. So maybe one of the best examples in this, and we heard it right at the beginning this morning, is this idea that one of the 4 or 5 key ways that get set out in the logic models by governments is that if we reduce availability, we reduce consumption. And we have endless amounts of activity related to reducing availability. Police activity, licensing activity, all of these are considered public health policy interventions, yes? However, it's absolutely clear that today in Wales, alcohol is more readily available than it's ever been, despite all of these particular interventions. No real particular surprise there, yes? New drugs just able to spring on the market and rapidly come available despite anything we want to do. So we now know that we're reaching an almost public hysteria about NPSs at the moment, novel psychoactive substances. Drugs are made freely available inside prisons, no matter how much we try to say that there are drug-free environments and all sorts of things. So not necessarily we can demonstrate that we've done all the activity of the policy, but actually it doesn't always result in changes, yes? Yes? At another level, yes, some people will tell us at the moment, and it's quite clear, that overall consumption of individuals in Wales in relation to their alcohol is to some extent or another reducing. Can the Welsh Government claim that as a consequence of its policy? Is that purely an austerity-driven thing? Is it a generational thing? If I'm of that generation that's most at risk, and I drink like a fish and I smoked drugs, because that's what a larger part of my generation did, maybe the only way that my kids get to rebel is not to drink. Is that a consequence of Welsh Government policy? So we have all of these challenges that we try to explore, yes? I will and we will be able to report on the more specific findings of what we've done in the Welsh Government frame, but I hope that gives you a kind of flavour about the thing that you start to struggle with this methodology. It has a number of implications, and I just want to highlight some of those for you. And these are emerging implications for people as we begin to use it, yes? We're able to begin to understand individual behavioural change re alcohol and drugs is a relatively small part of the overall picture for both the individual and the society. So we've heard that very, very clearly today from Winfred and others, yes? Individual behavioural change at the end of a treatment intervention does not equate with long-term individual or societal lifestyle and recovery outcomes. In fact, without anything else, it probably results in only that and a likelihood of a return to the addictive behaviour, yes? And a clear outcome and goal for policies might even not be alcohol or drug related. Yeah? And they're not. Yeah? One of the principal alcohol and drug related outcomes that we've wanted as a society for ages is a reduction in crime. We don't care at that level whether people are using drink or drugs, as long as they stop nicking stuff from people's sheds. Yeah? We need to begin to get to some very non-binary approaches to evaluating really complicated interconnected policies. It's probably not possible to say that policy X is delivering policy Y, yes? One of the ways that this may get turned on its head, of course, is that the Welsh Government may be one of those first governments to decide it doesn't have lots of policies. And it tries to do this funny, peculiar business of saying we're only going to have 3 or 4 policies for the whole of the country. We're going to have a health and well-being policy. We're going to have an economic and environment policy, yes. We're going to have an education and early years policy. You know, we try and do everything in policies as a way of counteracting this idea of interconnectivity, yes. We're going to have to develop far more sophisticated logic models. So the current logical model of substance misuse just says harms, reduction of consumption, reduction of availability, reduction of harms. Far more complicated logical models are going to be required in the future. Yes? We're going to have to turn over a balance in the way in which we work in public health between monitoring. So we do have to monitor the activity, we do have to count the units, we do have to get all that core data, but actually we can't just do that. We're going to have to step into this other new form of data collection as well. And in relation of alcohol and drug area, we're definitely going to have to do far more longitudinal studies of individuals. There's only ever been one significant long-term longitudinal study of alcohol and drug use in the UK. That was the NTOR study, one study, 5 years, and it had more influence on policy than almost any other study. And all of you who have never read NTORs will have come across it if you'd have seen any of those statements that said every £5 spent on treatment resulted in, or £1 spent on treatment resulted £5 somewhere else, and all that sort of thing. So we're going to have to get away from these very narrow logic models. They invite narrow considerations, and they invite narrow considerations about a small number of sick people who need treatment. And we heard very much earlier on this morning that we're increasingly going to have to talk about whole populations on continuums. You know, and I'm very much in that camp. Yeah? You can chuck your DSM-V5 and all the rest of it into the river as far as I'm concerned. Yeah? So we're really interested in whole population use. We're going to have to understand that people's use, and we've also heard this today, is a response to a whole range of other issues as much as it is the cause of the problem. And policy is going to have to try and reflect that, and we're going to have to try and evaluate it. We're going to have to understand that use is not an isolation. It's part of culture, family, society, and lifelong journeys. And you've also heard a lot of that this morning. And we're going to have to capture that in a way in which we begin to evaluate the success of policies and interventions. And essentially, we're going to have to increasingly complex, diverse set of particular individual groups. Older people over 65 are going to have to be monitored and evaluated in a very different way to 16 to 24 years, and all of that sort of thing. And where does that leave us? It leaves us in Wales at the moment in a place where the Welsh Government has chosen its first two pieces of legislation around public health matters to be the Social Services and Wellbeing Act and the Future Generations Act. So they've stuck their mast to these conversations, whole population interconnected conversations, not very narrow pieces of legislation. Yes? And anyone who's involved in supporting any of the individuals responsible for delivering some of this stuff are being told that the new way of having a conversation with people who come through doors wanting to seek support or soap is to have what's known as the what matters conversation. In other words, what matters to them. And if that starts to become the starting point for where you start to deliver interventions, somehow we've got to find it to be the end point in measuring whether or not those interventions and policies are successful. And we can't do that in the traditional way we've been doing it. Thank you very much.